This is Bill O'Neill. I'm the medical director for the Center for Structural Heart Disease at Henry Ford Hospital and a practicing interventional cardiologist. I think the finances of TAVR are fascinating and tricky. And I would go back to open heart versus stent. You know, if you have a patient that has 3-vessel disease and has a bypass operation, most hospitals make between $5,000 and $10,000 of profit on that surgery. Now, if you take that same patient and you put in 3 to 5 drug-eluting stents, they're going to lose $5,000. And so there's been a lot of places where, cardiologists have been pressured to send the patients to open heart because it was a much more profitable procedure. I think there's going to be a similar sort of cost analysis. It's still a little too early. TAVR is a buzz. Every big medical center sort of as a point of pride wants to get involved with it. But the strict finances, I think, are going to become problematic. First of all, you have 2 physicians, a cardiologist and a cardiac surgeon, that are involved in about a 3-hour case. And those cases pay a split of a fee from CMS. And so on a strict basis, a surgeon or a cardiologist could do far more billable work on their own doing either cardiac surgery or interventional procedures. Secondly, you need to have a cardiac anesthesiologist, and third, you need to have an echocardiographer. So there are 4 physicians involved in a 3-hour procedure, and you're getting paid about 1.3 worth of physician effort for that. It's really unlikely that in private practice, with the current private practice mechanism, that any private practice physician would be able to make a living doing this. So I think that this is going to be centered in large academic centers where the cost and profit can kind of be splayed out more evenly. There are a lot of spin-offs, so the ancillary testing, echocardiograms, MRIs, CTs, cardiac caths, and then the imaging that's required for the follow-up, I think, is going to help offset some of the adverse reimbursement during hospitalization. A lot of it is going to be driven on how complicated the patients are. If the patient has a very simple procedure, we can get them out within 48 hours, and then the institution does make a profit. If the patients are in the hospital for 1 to 2 weeks, the hospital loses money, and then if they're in the hospital for greater than 3 weeks, the Medicare DRG for extreme cases takes over, and the hospitals do make some money. So there's going to be wild shifts in revenue. It still is very complicated. I think at the end, the numbers of places that do these are going to decrease just strictly because of the financial pressures.